to be presenting and introducing Magdalena Cerdá. She's a professor and director of the Center for Opioid Epidemiology and Policy in the Department of Population Health at NYU Langone Health. She and I first met in 2011, I think, more than 10 years ago, when I was doing a postdoc at Columbia. She was an assistant professor there. We've been good friends and colleagues and have met for a while ever since. Prior to that, she obtained her doctorate from the Harvard University School of Public Health in 2006, and was also a former Robert Wood Johnson Health and Society Scholar. Her research focuses on many different domains. She has research studies looking at the state and national drug and health policies and the effect they have on substance use trends in the US. She's also looked at the effect and impact that cannabis laws and opioid policies have on substance use, mental illness, and associated health problems in the US. She's also done comparative work in South America as well. And today she'll also be speaking about her work in firearm injury and its relationship with mental illness and substance use and the effect that it may have on population level rates of morbidity in the United States. So with that, please join me in welcoming Dr. Magdalena Cerdá.
Thank you so much, everybody, for coming today, and also for everybody online for listening in. So today I thought I would talk about share some thoughts about how I think we can use epidemiology to inform an effective response to two leading public health problems: overdose and gun violence. So US life expectancy in the United States. So this is a graph of the United States. And life expectancy in the United States right now is the lowest it's been since World War II. So we've really experienced a great decline in life expectancy in the past 20 years. In my work, I deal with two of the biggest drivers of that decline in life expectancy, and those are drug overdoses and gun violence. As you can see here, this is a graph showing you the 10 leading causes of death in the United States for 2021 by age group. And the shaded areas indicate unintentional injuries, which is the main driver there is actually drug overdose. And then homicide and suicide, the main driver there is gun-related homicide and suicide. So as you can see here, across all age groups, gun violence and drug overdoses are actually one of the top 4 leading causes of death. So huge public health problems. And so for me as an epidemiologist, what I really care about is figuring out how I can use epidemiology, how I can use different kinds of scientific methods to figure out how we can do better and address these two problems. And so if we think about that, our role as epidemiologists in addressing these problems, what can we do? So I think, well, there's many things we could do, but just in the interest of time, today I'm going to highlight 3 questions that I think we can answer. First, we can inform policymakers and the public about the impact that state and local laws have on access to evidence-based interventions to reduce the risk for injury and death. Second, we can figure out how and where should we target intervention for maximal impact. And third, we can inform what types of interventions could work best for each setting and population. So in today's talk, I'm going to try to show how we can answer those questions, focusing on the overdose crisis and on gun violence, starting out with the overdose crisis, presenting a profile of the problem, and then some examples of our work, and then moving on to gun violence and operating costs for the future. Okay, so the first is solutions to the overdose crisis. So in my center, that's really what we're focused on. And so the work that you see here is actually work of all of us together. And also, very importantly, a lot of the work that you'll see here is in partnership and actually led by Brandon Marshall's team and the team at RAP, and a lot of you who are here today. Okay, so unfortunately, the United States has the bad distinction of being a leader in opioid overdose deaths across the world. As you can see from this graph, the United States is one of the highest rates of overdose deaths across the world. And so far in its current iteration, the overdose crisis has gone through 4 waves. It started out in the late 1990s with the proliferation of the use of commonly prescribed opioids to treat chronic non-cancer pain. That's the green line that you see in the graph. Then the crisis evolved to first involve heroin, that's the purple, and then more recently we've gone through 2 waves, the blue and the red, which are really overdoses mainly driven by illegally manufactured opioids, illegally manufactured synthetic opioids, in particular, as you may have heard in the news, fentanyl. And increasingly also in combination with stimulants such as methamphetamines and cocaine. Now, if you, although this is a national crisis, it doesn't impact everybody across the country in the same way. This is a map, actually, we estimated state and year-specific overdose deaths rates by type of opioid product, heroin, prescription, synthetic, and unspecified. And as you can see here, there's a lot of heterogeneity. So while there are some states that have experienced all 4 waves of the crisis, there are other states that have been largely unaffected. Just to give you 2 examples, if you contrast Nebraska, right, flat low rates throughout the crisis, and you contrast that to Rhode Island, and Rhode Island is actually one of, I think it has the 15th highest rate of overdose deaths in the country, and it has experienced all 4 waves of the crisis, the latest one being the really driven by synthetic opioids, the blue line. So to me, this really highlights 2 things. First, that we need a localized response to this problem. And second, that I think we can probably learn from other states like Nebraska and other states that have been unaffected, and to try to figure out why is it that they're unaffected and what can we learn from that to apply to other places where we've seen them really bearing the brunt of the problem. So if we think about how can we address this problem, I think there's really 4 leading approaches. First is regulating the opioid supply, and historically that has really taken the shape as regulating opioid prescribing. Remember, I said at the beginning, this problem really started the rise of the use of prescription opioids to treat chronic non-cancer pain. So a lot of the work has really been around trying to address that by regulating the opioid prescribing. Second is reducing harms associated with drug use. Third is improving access to evidence-based treatment and for opioid use disorder. And finally, tackling some of the social drivers of drug use-related harms. Today, the examples that I'm going to be talking about really focus on the first 3 approaches. So again, if we ask this question about what are some of the questions that epidemiologists can help answer to address these critical issues, I'm going to be talking about, some of the work that we do evaluating the impact that state and local laws have on access to evidence-based interventions and their impact on overdose deaths. Second, the question that I posed at the beginning about how and where we should target interventions. I'm going to give you an example of that work that we're doing in collaboration with colleagues here. And then the third, what types of interventions work best, some of the work that we're doing modeling optimal types of intervention packages. So the first is evaluating the impact of state and local policies on overdose risk. We do a lot of work on this. In fact, this is a really a large part of our work at our center focuses on evaluation of policies. So if we, again, as an illustration today, I'm going to start out by showing you an example of the work that we're doing in the policies that aim to regulate the prescription opioid supply. So when I think about evaluating the impact of policies that regulate the prescription opioid supply, I'm interested both in the intended effects that these policies can have, but also on their potential unintended effects. And so what do I mean by that? So this is a graph that shows you the opioids prescribed in the blue bars, and then you have overdose deaths involving commonly prescribed opioids in red, and other synthetic opioids, illegally manufactured mostly in the blue, and then heroin in the green. And so what you can see here is that as opioid prescribing in the blue increased, so did overdoses involving commonly prescribed opioids. However, as states and the federal government enacted a number of measures to regulate opiate prescribing, overdoses involving prescription opioids stabilized. However, the other thing you may notice, is that while prescription opiate overdoses stabilized, you could call that a success, overdoses involving heroin and synthetics actually increased. And so that to me raises a question about could these policies that make it harder essentially for people to access prescription opioids, could they be having an unintended effect of transition into opioids in the illegal market? And so how could this happen? If people have become addicted to prescription opioids and suddenly it becomes more expensive and harder to access those opioids, could they be then shifting to drugs in the illegal market? And could that be explaining part of the rise in overdoses involving heroin and synthetic opioids? So we've looked at this question of potential unintended and intended consequences, evaluating a number of different policies that regulate the prescription opioid supply. In the interest of time, I'm just going to focus on one example, which is one of the leading state policies enacted to regulate opioid prescribing, and that's prescription drug monitoring programs with mandated queries. What is that? That essentially PDMPs are a comprehensive database that physicians or healthcare practitioners have to check that collects information on controlled substances. And so the idea is that healthcare practitioners will check the database and actually are legally required to check the database before prescribing a controlled substance like an opioid, and pharmacists have to also check it before dispensing a controlled substance like an opioid. And so the idea is that this could potentially prevent inappropriate opioid prescribing and dispensing. Now, some work, including by our group, that evaluated the impact of PDMPs in the first wave of the crisis. Remember, I said that was really driven by overdoses involving prescription opioids. That work showed that PDMPs were successful in reducing inappropriate prescribing and in reducing prescription opioid overdose deaths. But the question is, what's their impact now in the current state of the crisis, where we're not talking about a crisis driven by prescription opioids anymore? We're really talking about a crisis driven by illegally manufactured opioids. And so that's the question that we asked in our study. So we looked at the impact that state adoption of PDMP must query provisions, that is, requiring dispensers and prescribers to check the PDMP before prescribing and dispensing, what impact that had on two things. First, on indicators of high-risk opioid prescribing, that's high-dose prescribing, 90 morphine milligram equivalents or more, and long-duration prescribing, that's 30 or more days. And we looked at those outcomes at the county level. And so if you look at this graph here, what you're seeing is that indeed adoption of a state PDMP must query provision was associated with a decline in both high dose and long duration opioid prescribing. So if you look at this, you say, great, achieved one of its objectives. It was successful. Okay, but then what happens with overdoses? So this graph shows you the relationship, the risk difference associated with state adoption of a PDMP must query provision, and the outcome is different types of overdose deaths at the county level. And so when you look at any overdose death, and then the next circle is any opioid overdose death, you actually see an increase in overdose deaths associated with the adoption of a PDMP must query. Now, if you focus on prescription opioid overdoses, that's the next circle down, you can see actually maybe a slight decline, right, as expected. But we are seeing an increase in overdoses involving heroin and illegally manufactured synthetics. So really, what's driving this overall increase in overdoses associated with the PDMP must query provision is driven by the increase in illegal opioids. And so that to me suggests that indeed, at the current time, although state PDMP must queries are important in terms of regulating prescribing, they are potentially having this unintended consequence of contributing to the rise in overdoses involving heroin and synthetic opioids. And so that doesn't mean we must throw away PDMPs. It just means that at the same time that we invest in PDMPs, we need to invest in other strategies like access to treatment for opioid use disorder and harm reduction services to address some of these unintended consequences. Okay, so that leads me to the second piece, which is harm reduction, right? At the same time that we regulate opioid prescribing, we want to reduce the harms associated with drug use. And with harm reduction, what we mean is really meeting people where they are and providing them the services they need to be able to lead a life with health and dignity. Steve.
Just wanted to, if you're gonna be, I think, presenting a number of studies, would you rather we hold questions to the end?
Yes. Yes. All right, so one of the leading policy approaches, one of the leading harm reduction policies adopted by states, actually most states in the US right now, is what are called overdose Good Samaritan laws. And so these laws, what they try to do is they try to encourage bystanders to call for help in the case of an overdose by reducing the penalties associated with drug possession. The issue with Good Samaritan laws is that they don't look the same in all states. In fact, in some states, they protect people from being arrested for drug possession if they call for help. But in other states, they may still be arrested, but maybe they're not charged, or maybe their penalties are less. So you can imagine that your willingness to call for help may really vary depending on what level of protection you're afforded as a bystander. So we looked at that. We actually looked at the impact of different types of Good Samaritan laws on overdose deaths. We looked at them in conjunction with laws that make naloxone more available because the two types of laws co-occur, so it's difficult to disentangle the two. And so what you can see here is two graphs, one showing you the effect of the adoption of Good Samaritan laws, two types. Good Samaritan laws that protect from arrest and Good Samaritan laws that still mean that people are arrested, but they may not be charged. And the left-hand side graph shows you the effect on opioid overdose deaths, and the right-hand side graph shows you the effect on heroin and synthetic overdose deaths. And so what you can see is that while protection against a charge is not going to lead to a reduction in overdose deaths, Good Samaritan laws that provide the most expensive protections, protection against arrest, are effective in terms of reducing overdose deaths, and importantly, reducing overdose deaths involving heroin and synthetic opioids. Now, beyond making it possible for people to call for help, harm reduction also involves a number of different types of services, including syringe distribution programs to protect people from infectious disease transmission, drug checking equipment so that people can make informed decisions about the types of drugs that they're consuming and strategies to use drugs, overdose prevention centers that offer safe spaces for people to consume their drugs and receive services in case of an overdose, and naloxone distribution, which is a medication to reverse overdoses and prevent deaths. Now, although a lot of evidence suggests that these harm reduction services are very effective in improving the health of people who use drugs, unfortunately, they're not widely available across the country. We, for example, looked at the number of counties that had community-based naloxone distribution. Again, naloxone, an effective tool to reverse overdoses, and we found that only 15% of counties have community-based naloxone distribution programs. So making harm reduction services more available is a huge priority. Now, harm reduction service availability is partly shaped by laws, both at the state and the local level, that regulate, for example, whether syringe service programs can operate or regulate the distribution and possession of drug paraphernalia like syringes or naloxone or drug checking equipment. So because of that, a lot of research has looked at state harm reduction laws, but they haven't really looked at the role that local laws may play in actually shaping access to harm reduction services. And that really inspired us to do a new study where we're drilling down to the local level and figuring out what municipal laws can both amplify and restrain availability of harm reduction services and can shape both overdoses and drug-related harm. In this study, we are looking at three different types of laws at the municipal level. First, laws that regulate the possession and distribution of drug paraphernalia. and naloxone. Second, laws that authorize the operation of certain service programs. And third, laws that declare the ability to declare rental properties a nuisance, and drug use is one of the reasons to declare property a nuisance. In this study, we are collecting information on these laws for 486 municipalities of 75,000 people or more across all 50 states. So, what's our biggest challenge here? So, one of the biggest challenges in this study is actually collecting the data on these municipal laws. It's a huge time-consuming process. So, for example, of the 3 laws, so far we've collected the data for the 486 municipalities for 2 of the 3 laws, and it took us a year. We're also concerned about inter-rater reliability. We have 2 raters actually collect the information for all the laws, for all the municipalities. And sometimes you can imagine that raters differ in whether they identify a law or not. But finally, when you're doing manual extraction of data, you have to develop a data collection protocol at the beginning of your study and then stick to it, right? Because otherwise, if you suddenly change like 6 months down the line, you realize, oh, I should have asked about this, but you can't go back because that means going back and redoing everything, and that's really time consuming. So these are some of the issues that we've been struggling with. So that led us to ask, is there a different way that in the future we can reliably and feasibly update laws over time? And so a new project that we are currently working on is using automated coding, using a large language model to be able to basically automate the collection of data on these laws. We are fortunate that we will have manually extracted data on all of these laws for all of these municipalities, so that then we can develop this large language model and test it against the manually updated data. And then hopefully we can use this large language model to update the data annually. The approach that we're using is called retrieval augmented generation. And so what we do is we start with a collection of municipal codes and research queries. So for example, here you take the city of Chicago and we ask the question, does this jurisdiction have an ordinance imposing penalties related to drug paraphernalia? Then we use an embedding model to index the source documentations and to retrieve potentially relevant text. Then we use a large language model to evaluate the segments that we've identified and generate a coded response. So for example, this piece of the code, is it relevant, is it not relevant? And then answering the question, yes, the Municipal Code of Chicago does contain provisions related to drug paraphernalia. And then the model can actually provide citations, can provide excerpts of the retrieved segments, and provide a rationale for validation of the model. And the idea is that this model may actually do better than human raters, because instead of just focusing on a keyword search, it will actually be able to leverage semantic evaluation of text and go beyond what keywords could do in a much faster amount of time. And as you can imagine, if you suddenly come up with new questions that you want to ask, that's just changing a line in the code and not going back 6 months and redoing everything. So this is a very high risk, but hopefully high reward project that we're currently working on. So stay tuned for findings. Okay, so the second piece of our work around using epidemiology for overdose, to tackle the overdose crisis, is forecasting where and how to target interventions. And this is work led by Brandon in collaboration with our group, and a lot of the people involved in that are here today. So one of the challenges that community-based organizations that are delivering services to prevent overdose deaths and to protect the lives of people who use drugs is, where do we allocate those services? And the problem is that they're dealing with limited resources. And so they really want to locate those services in places that are going to have the maximal impact. So one way you could do it is you could just use historical data on overdose deaths and figure out and allocate them in those places with the highest rates of overdose. However, this problem of overdoses is changing so rapidly that past data on overdose deaths may not actually be a good source of information about where overdoses will happen in the future. And if we want to have maximal impact, we need to be proactive and really locate services where overdose deaths are going to happen in the future. So the study goal for the study called Provident was to leverage machine learning models to actually develop predictions about where overdoses would happen in the next 6 months, and then provide that information to organizations delivering services on the ground so that they could reallocate their services to those hotspots that would experience a rise in overdoses in the future. That led to our study goal, which was really to test whether these overdose prediction tools could reduce overdose rates by 40% in 5 years in Rhode Island. The study has two components. First, developing these machine learning models, applying machine learning models to develop these predictions of overdose hotspots in the future across Rhode Island. And then the second piece was we wanted to figure out the impact that providing community organizations with this information could have on overdose deaths. And so to do that, we designed a randomized controlled trial where we randomized towns to either receive information about the predicted hotspots and to help them steer services to those hotspots, and then randomized other towns to the control arm where they would not receive information about these predicted hotspots. So the first piece was the application of the machine learning models. And the aim with these models was to identify the 20% of neighborhoods across the state that would experience 40% of overdose deaths in the next 6 months. Why these metrics? So these were metrics developed in conjunction with the Rhode Island Department of Health. And again, they're out of this need, this issue about limited resources and this need to really focus intervention in the places that are going to bear the brunt of the burden. So we compiled, and thanks to the team here, like Claire, Patty, and Max Krieger, who made it possible to compile all of a range of treasure trove of data that you guys have. It's amazing the data that's available in this state. That made it possible to compile data on the census and a range of surveillance data. Then we used a range of different types of machine learning models using an ensemble model to find the optimal predictions of what neighborhoods in the state would experience the highest rates of overdose in the next 6 months. We were able to obtain a model that successfully identified 40% of overdose deaths in 20% of neighborhoods. So that's really great, but these data are only as helpful as they can actually be delivered and have an impact on the ground. And so that takes me to the second piece of this project, which has really been led by the team here at Brown, where they worked to make the data available to community organizations. And they've done that in a number of ways. One is developing these dashboards that provide community organizations with a map of, for example, this is just a snapshot of Providence, a map of showing where the prioritized sites would be, where the hotspots are predicted to be based on our model, and providing information about what those neighborhoods look like, and then holding a number of what are called data use academies to familiarize community organizations with what do these predictions mean and how they can use them to steer their services. Right now, we are in the process in the last year of the study, and we're actually evaluating the impact that all of this has had on overdose deaths. So also stay tuned for results. Okay, so imagine you evaluated the impact of laws, you figured out where to intervene. The third piece of the puzzle is figuring out if you know where to intervene, how are you going to intervene? And so I think a third piece of our role as epidemiologists is helping jurisdictions figure out what are the optimal intervention packages for different settings and populations. So one example, we do a lot of work figuring out what are optimal intervention packages, and one I think illustrative example is work done with the Healing Community Study. The Healing Community Study is a cornerstone of the NIH response to the overdose crisis. And the aim of this study is to reduce opioid-related overdose deaths by 40% in selected counties in 4 states: New York, Kentucky, Massachusetts, and Ohio. And they use a parallel group cluster randomized waitlist control trial to do this. So in these 4 states, academic communities are working with practitioners and policymakers to figure out what kinds of interventions need to be implemented in their counties in order to achieve the 40% overdose reduction target. The problem is, how are communities actually going to figure out where to allocate resources to reduce overdoses by 40%? What kinds of interventions should they be focusing on? So in the state of New York, my colleague Catherine Keys and I used agent-based models, a type of computer simulation model, to help New York counties in the study figure out how much they would need to invest in the delivery of 2 types of interventions in order to achieve the 40% target. One is delivery of medication to treat opioid use disorder. That's, in particular here, we're focusing on buprenorphine, shown to be highly effective at treating opioid use disorder. And the second is delivery of naloxone, again, highly effective tool to reverse overdoses and prevent deaths from overdose. We conducted this simulation across counties in New York State, but we thought that the potential investment needed in medication and in naloxone might really depend on the pre-existing treatment infrastructure available in the county, and might depend on urbanicity in the county. So we stratified our models by treatment availability and urbanicity. I'm not going to present all of the results here, but just I'm going to present results for 2 counties to illustrate the level to which context really seems to matter in terms of how much investment is actually needed. So here are simulation results showing you the percent reduction in opioid overdose deaths in the y-axis that would be achieved with different levels of increase in buprenorphine initiation and in the lower x-axis, and naloxone distribution in the upper axis. And so what you see here, this is an urban county with high pre-existing levels of treatment availability to treat opioid use disorder. In this type of county, you would need a 150% increase in the initiation into medication to treat opioid use disorder, and a 200% increase in naloxone distribution in order to reduce overdose deaths by 40%. However, the amount needed is very different in a rural county with low pre-existing levels of treatment. In this type of county, so this is the same kind of results, but here I'm talking about a rural, low treatment access county. In this county, you would need to increase treatment by 300% and naloxone by 1,000% in order to achieve that 40% reduction. These are huge numbers, right? Probably unfeasible increases. But it really, again, highlights the need for a localized response that considers the pre-existing infrastructure if one is to have maximal impact. So I went through a tour of 3 different types of questions that we can ask as epidemiologists to address the overdose crisis. Just to bring it back home and summarize, overdoses are increasing across the country, particularly with overdoses in combination with stimulants. We know that regulating opioid prescribing did decrease high-risk prescribing, and it decreased prescription opioid overdoses. But it also, in the current stage of the crisis, is having some unintended consequences. Harm reduction services are critical, but they're limited. And we think that state and in particular local laws can be important levers to evaluate. Finally, I think we can use epidemiologic methods to evaluate what works, to forecast where and how to target interventions, and to advise jurisdictions about the optimal intervention packages that they may put in place to achieve their targets. Okay, so now I'm going to switch to a different topic, which is gun violence. And so you may think gun violence, overdose, not so related. In fact, they are related because there's a link between drug use and risk of victimization by gun violence. There's also, we can think of common approaches to address gun violence and drug use. So I think there's actually value in thinking about the links between the two of them. So unfortunately, I really choose very happy topics in my research, but gun-related injuries are another huge public health issue in this country, and they've only become worse since the start of the COVID-19 pandemic. In 2021, more Americans died of gun-related injuries than any prior year on record. One of the biggest drivers of the cause of death from homicide and suicide is gun availability. The United States has the highest prevalence of firearm ownership in the world. So if I think about what I can do as an epidemiologist to address this problem, particularly for the problem of gun violence, I'm interested in figuring out what types of interventions work best to address this problem in different populations. And the work that I do is using agent-based models to simulate the potential intervention packages that could work for different settings and populations. So if we think about what to do, what types of interventions to focus on, I think there's a range of different interventions one could focus on. The first is really firearm regulations that can shape access and use of firearms. And with firearm regulations, we can think about two different kinds of approaches. One is a high-risk approach that really tries to limit access to firearms among those groups that are going to be at the highest risk for perpetration or victimization by gun violence. In contrast, we could also think, as epidemiologists, care about population level rates of outcomes. We can think about a population-based approach that actually increases the costs associated with firearm use across the whole population. Also, in addition to regulating firearms, we can also think about violence prevention interventions that address the social and economic drivers of violent behavior. We published a lot on the use of agent-based modeling to understand the propagation of violence and ways to address it. I think agent-based models are really an ideal way to answer kinds of questions that we can't answer with real data about what types of interventions might work best where and at what dose. And so that's really what inspires our work in the area of gun violence. This is work done also in collaboration with Catherine Keats at Columbia University. And we are doing our work in New York City. We created a computer simulation model, an agent-based model that resembles the neighborhoods of New York City. So if this is New York City neighborhoods, we create a grid that represents the size and location of New York City neighborhoods, and we populate the neighborhoods with agents that are represent adults in the city of New York. So I'm going to show you an illustration of the potential impact that two types of approaches to regulate access to firearms could have on gun violence using this model from New York City. I'm going to contrast a high-risk approach, so really targeting the most high-risk population, with a population-based approach. So first focusing on a high-risk approach. So here, remember I said, what's the connection with drug use? Well, alcohol and drug use are two of the strongest predictors of firearm violence. In fact, 20 to 30% of prisoners report being under the influence of alcohol or drugs at the time of violent crime. About a third of firearm homicide perpetrators were acutely intoxicated at the time. Importantly for our study, a California study actually found that people with DUI convictions before they purchased a firearm had nearly 3 times higher risk of violent crime. And so these data inspired us to ask the question, what could happen to firearm homicide if we prohibited people with a prior DUI history from purchasing firearms? So here are the results. So we ran these agent-based models, and we looked at the potential impact of firearm disqualifications based on a history of DUI among 2 populations. First, starting out with just the population that's affected, the high-risk population. What happens with them if we prohibit them from purchasing firearms? So this is showing you among agents with a prior DUI history, the bar in this blue bar here represents the baseline condition, no intervention among agents with a prior DUI conviction. And this solid green line shows you the baseline situation among agents with any kind of DUI. And so what we find is that among agents with a prior DUI conviction, prohibiting them from purchasing firearms could lead to about a 9% decrease in firearm homicide. And then among people with any kind of DUI history, it could lead to up to a 27% decrease in gun-violent and gun-related homicides if these people were prohibited from purchasing firearms. So among the high-risk group, you can see a pretty sizable effect of these prohibitions. The problem is that we also care about what the impact of these measures could be at the population level. And so what happens if you look at the population level? So here are the findings among the general population. And so here, the purple bar in the left-hand side is the situation with no intervention. And then the subsequent bars are the level of decrease in gun-related homicide with prohibiting people who had a DUI misdemeanor conviction or DUI arrest. And so essentially what you find is that there's a very small, if any, effect of these firearm prohibitions at the general population level. So while prohibiting people with a prior DUI history from purchasing firearms may have an important effect within that population, it will not translate to a population level decrease in firearm homicide. Okay, so because we're epidemiologists and we care about, Jeffrey Rose's prevention paradox and the value of intervening at a population that may overall have low risk versus intervening on high risk population, that led us to ask a different question, which was, what about if we intervened across the whole population? What about if we increase the costs associated with firearm use across the whole population? And so that inspired this second study, which asks, if we want to reduce population level rates of firearm violence, how far should we expand our focus? How far should we expand the population that will be affected? So how far would we have to expand intervention effects to reduce firearm homicide? And so in this new study that I'm going to show you some results for in a second, we're contrasting a high-risk approach with a population-based approach. With the high-risk approach, I'm going to show you the results for 3 different scenarios. I'm going to show you the decrease in population level rates of firearm homicide if we prohibited firearm possession from 3 different groups. The smallest group is people with a history of involuntary psychiatric treatment or a DUI conviction. A medium-sized group, people with a domestic violence restraining order or a drug misdemeanor. And the largest group, people with a felony conviction or misdemeanor conviction. So essentially, how large do we need to define the high-risk group in order to get the population level effect? And then we're going to contrast that with a population-based approach, which is raising the price of firearms through an excise tax to the whole population. And so what do we find? And so here we're showing you the gun-related homicide rates in all of these different scenarios that I just mentioned. Again, this is the base rate of gun-related homicide with no intervention. And then we go to what happens if we just prohibit firearm purchases in the low prevalence population. Pretty much no effect at the population level. In contrast, if we prohibited about 50% of the moderately sized high-risk group, or about 25% of the largest high-risk group from purchasing firearms, we could have a 10% decrease in firearm homicides. In addition, or in contrast, if we enacted a population-based approach and increased the price of firearms across the whole population by increasing the tax, the excise tax, we could also achieve the same effect. So larger high-risk groups or population-based effects or population-based interventions, a 10% decrease. But I think what's really interesting here is the red bar. What does this show? It shows that really, as with everything, it's not an either or situation. It's not just high risk and it's or population based. It's both together. Because if we actually invest in prohibiting high risk groups from purchasing firearms and increase the price of firearms, we're actually going to get double the amount of decrease in gun violence. So this really highlights that we need a combined approach to have maximal impact on this problem. Okay, so at the same time that we're intervening in firearm availability and access, we also need to invest in addressing the social and economic drivers of violent behaviors. There are a number of randomized trials that have found certain interventions to be most effective, including investment in supportive social services for people at high risk of violent perpetration, including connecting them with employment and education, and investment in clinical counseling and mentorship. And so that led to the Violence and Inequality Project, which is led by Pat Sharkey out of Princeton. And what this project is doing is trying to provide a public resource to make data on violence accessible to the broader public, and then to leverage different types of methods to identify what are the most effective approaches to reduce violence in cities. We're using quantitative data, qualitative data, and most relevant to me, agent-based modeling. And so that's really the piece that I'm working on with Pat and with Catherine Keyes to figure out with agent-based models, how would we have to intervene using these evidence-based approaches shown to be effective in trials to be able to get a population level decrease in gun violence. And then part of the intent of this project is to engage stakeholders in the use of these data to inform their own violence prevention approaches. The data is made available through this website, americanviolence.org, where you can actually get data on homicides and shootings across the country. So again, we're using another example of using agent-based models to inform city-level action, simulating trends in shootings in cities, and testing the population-level impact of a range of different interventions. I'm not going to really get into this just because I see I want to leave a little bit of time for questions, but essentially what we're creating, we started with the city of Chicago, and we're creating a model of Chicago residents, adolescents, young adults, and adults, and modeling processes of group retaliation, violence exposure within social networks, and violence exposure within neighborhoods, and then modeling the effect that different kinds of interventions that have been shown to be effective in reducing violence, what impact does that have within the target group, but then how does the impact of that intervention propagate across the social network and across the neighborhood? And to give you an idea of what this looks like, we built a model where we're nesting people within neighborhoods, then we're grouping them into tiles that reflect the social networks, and then grouping tiles to reflect gang formation, and then we're connecting agents to each other and allowing them to relate to the geographic environment. And then we are allowing 3 different types of tension to arise in the network: group tension reflecting gang violence, agent tension within the network, and then neighborhood tension. And then at the current time, we're working on the intervention piece. We're using this model to understand what could be the system level effect, the network and the neighborhood level effects of 3 different types of interventions: Ready Chicago, One Summer Plus, and Become Demand. These are interventions that really invest in employment, mentoring, and counseling for populations who have been shown to be at high risk for violence. We will be having results in the next year, so stay tuned. So now that I've gone through some of the work on gun violence, to close it up again, firearm prohibitions that target multiple high-risk groups, I think, have the potential to reduce firearm homicide. But the effectiveness of high-risk approaches really does depend on the size of the group, the strength of the relationship between the risk factor and violence, and the extent, obviously, to which the group is actually effectively disarmed by these prohibitions. At the same time, I do think that modest population-based approaches can have the same impact as high-risk approaches that are imperfectly implemented. And we can maximize the reduction in gun violence by doing both, implementing high-risk approaches in combination with population-based approaches. Simulation models, I think, really offer a great potential to help us and help advise jurisdictions about what the optimal intervention package could be to have the greatest impact on this huge public health problem. So now that I've talked about overdose and gun violence, let me put it all together. People in the United States are dying at younger ages than their counterparts in other high-income countries. And I think drug overdose and gun violence are two of the leading reasons why that's happening. As epidemiologists, I think we need to do our part to address this problem. And we can do that by helping jurisdictions evaluate the impact that their policies and interventions are having, forecasting emerging trends to advise jurisdictions about where they need to implement their interventions, and advising jurisdictions about what types of interventions they should be investing in to have the maximal impact. In some of the future work, I'm going to try to pursue novel research on the connections between the gun violence and the overdose crisis. We're going to continue with Brandon our work in tracking emerging trends and forecasting overdose hotspots. And I'd really like to foster innovation to advance the equitable reach and impact of effective policies and interventions to prevent overdose and gun violence. Thank you so much to my collaborators here.